Good day, and welcome to the Key Opinion Leader Call on Cardiac Complications of DMD, hosted by Capricor Therapeutics. I will now turn the call over to A.J. Bergman, CFO of Capricor Therapeutics. Please go ahead, Mr. Bergman.
Before we start, I would like to state that we're making certain forward-looking statements during today's presentation. These statements may include statements regarding, among other things, the efficacy, safety, and intended utilization of our product candidates, our future research and development plans, including our anticipated conduct and timing of preclinical and clinical studies, our plans to present or report additional data, our plans regarding regulatory filings, potential regulatory developments involving our product candidates, and the uses of existing cash and investment resources. These forward-looking statements are based on current information, assumptions, and expectations that are subject to change, involve a number of risks and uncertainties that may cause actual results to differ materially from those contained in the forward-looking statements. These and other risks are described in our periodic filings made with the SEC, including our quarterly and annual reports. You are cautioned not to place undue reliance on these forward-looking statements, and we disclaim any obligation to update such statements. With that, I'll turn the call over to Linda Marquand, CEO.
Yes, good day, and thank you for joining us for this very important webinar on the impact of the cardiomyopathy in Duchenne muscular dystrophy. Let me remind you that while we are all preoccupied with the COVID-19 pandemic and the fear that comes as a result, for those boys and young men and their families with DMD, risk and fear is a regular part of their lives. Let me remind you that as DMD progresses, they see their lives changed and become more restricted with the continued loss of function from this devastating disease. It is with these thoughts in mind that Capricor maintains its focus on DMD and developing CAP-1002 as a potential therapy for this disease, with our goal of bringing this therapeutic to these patients as quickly as is possible. As you know, we have the 12-month data coming very soon for HOPE-2. We expect to have it available by mid-May now that all patient visits have been completed. Importantly, study patients who received CAP-1002 will have received up to 4 doses of 150 million cells intravenously over the course of 1 year. One of our goals with CAP-1002 is to treat the cardiomyopathy associated with DMD. While we also have seen improvements in skeletal and respiratory function, to our knowledge, we are one of the only therapeutics that has shown a direct and relevant impact on cardiac function in DMD. And, as you may know, the heart disease is often the cause of death in these boys and young men. Should gene therapies or other dystrophin replacement therapies work, there will be an even greater load on the heart as the patients will likely be more active. So therapies to treat the heart may even be more important than previously thought. We at Capricor have been laser focused on this treatment paradigm. To remind you, the therapeutic we are using, known as CAP-1002, is a unique cell known as a cardiosphere-derived cell, which originates from the heart. The cells function by releasing exosomes, otherwise known as nano-sized vesicles, that are taken up largely by macrophage and T cells and begin a cycle of repair. At this point, we have treated several hundred patients to date across a variety of clinical trials. Now, we also recently announced emergency or compassionate use program for CAP-1002 for the treatment of patients with COVID-19. I will provide you an update on that program at the end of this call, but for now, I would like to turn your attention to Dr. Michael Taylor, who will be speaking to you about Duchenne muscular dystrophy and the heart. It is my pleasure to introduce you to Dr. Taylor. Michael Taylor, MD, PhD, is a pediatric cardiologist at Cincinnati Children's Hospital Medical Center, where he directs the Cardiac Magnetic Research MRI program. In collaboration with the Cincinnati Children's Multidisciplinary Neuromuscular Center, his group has performed over 1,000 cardiac magnetic resonance studies in DMD patients for both clinical care and research investigation. He has published papers on cardiac function, myocardial injury, and response to therapy in Duchenne muscular dystrophy cardiomyopathy. Dr. Taylor joined the Heart Institute in 2010 as the Director of Advanced Imaging Innovation and Cardiac MR. He has expertise in cardiac magnetic resonance imaging of acquired and congenital heart disease in children and adults. He has a dual appointment in the Cincinnati Children's Hospital Medical Center Imaging Research Center, an interdisciplinary center dedicated to research MRI. Dr. Taylor's primary interests include cardiac MR and myocardial characterization, animal models of cardiac pathology, and novel MR techniques. He has an MD and a PhD from the University of Wisconsin, the PhD in physics, and postdoctoral training in pediatrics and cardiology at Baylor College of Medicine. It is my true pleasure to introduce you to Michael. Michael, take it over.
Good afternoon. I'd like to thank Linda and Capricor for the opportunity to talk to you about Duchenne Muscular Dystrophy and its effect on the heart. I'll go over some background about Duchenne Muscular Dystrophy, and then I'll talk about the cardiomyopathy of DMD, particularly what we know about the pathophysiology, the natural history, and I'll use our clinical paradigm as a framework for discussing evaluation and treatment. Finally, I'll talk about the current therapies that we have, one in HOPE-2 trials, and finish with a few words about how to think about DMD cardiomyopathy therapies going forward. So as most of you know, Duchenne muscular dystrophy is a devastating, progressive, X-linked muscle wasting disease that affects, we estimate, around 200,000 boys and young men worldwide. It's the result of a mutation in the dystrophin gene, and as a result of this mutation, muscle cells are replaced by a combination of fatty and fibrotic cells in skeletal, diaphragmatic, and cardiac muscle. The most striking aspect of the phenotype is loss of ambulation, usually by age 12 to 15. You can see the young man here in the wheelchair. Premature death from respiratory or cardiac failure is seen starting in the late teens, with average life expectancy now with current therapy somewhere around 27 years of age. There is no current curative therapy, but glucocorticoids or steroids do prolong ambulation and seem to provide some benefit to the heart, and I'll talk about this data as we go along. The causes of death and their frequency are seen here. The data is a few years old, and as of now, we actually think cardiac failure is responsible for closer to 50% of the known causes. Additionally, it's likely a primary or important contributor to patients who die of respiratory infections or respiratory insufficiency. So as you can see, finding a therapy for that can be used in all Duchenne patients, regardless of mutation, that either stops or at least slows the progression of the cardiomyopathy would be a tremendous clinical benefit. So Duchenne muscular dystrophy is actually categorized as a neuromuscular disease, and there's a whole range of neuromuscular diseases, as you can see at the table on the right, and some of them are associated with cardiomyopathy. In particular, Becker muscular dystrophy is actually also due to a mutation in dystrophin. The skeletal muscle phenotype is clinically milder in presentation, and most obviously externally, they don't lose ambulation until much later. However, the cardiomyopathy in Becker's tends to start a little earlier and is more aggressive. And the bottom line for the discussion, and why I bring it up, is that the evaluation and treatment is the same for us for both of these. The only exception would be therapies that are specific for a particular mutation. So essentially, we treat them both as dystrophinopathy cardiomyopathy. So the Duchenne muscular dystrophy itself, the incidence is somewhere around 1 in 3,100 males, up to 1 in 5,000. And as I mentioned before, it's a result of dystrophin mutation. The top diagram on the right is a schematic of a muscle cell. You can see the muscle cells are made up of fibers, and each fiber has a membrane that's responsible for its structural integrity as well as transport into the cell. Dystrophin, shown here in yellow, is a long tubular protein that connects the cell membrane to the contractile apparatus of the cell, specifically actin. So In the diagram below, which is a slightly more detailed picture, dystrophin is shown actually in green here, and it highlights the complex nature of the protein itself and its interactions with multiple proteins that are either on or near the cell membrane, which is important because as we go forward, you'll see that much of the pathology that results in Duchenne cardiomyopathy is a result of membrane disruption. As the dystrophin goes away and the patient's age, dystrophin muscle, the cells progressively die and are replaced. And by somewhere around 18 years of age, about 70% have detectable heart dysfunction. They all have heart dysfunction of some sort, whether we can detect it by our imaging or not. From a historical perspective, we've known about the pathology for quite some time. This is actually an interesting paper from 1966 from Los Angeles, long before we knew anything about dystrophin, showing the gross fibrotic changes of the heart on the left and the histology on the right that shows, just like we see now, multiple areas of what we call fibrosed adipose tissue or fibrofatty replacement of the myocardium. This diagram, I think, is a nice illustration of how we go from a single gene mutation to myocardial dysfunction and clinical heart failure. So if you start at the top with an abnormal dystrophin, it results in two primary pathologic processes, both of which have to do with the cell membrane. First, we have dysfunction of the membrane. Here we call it the sarcolemmal membrane or cell membrane, that causes dysfunction of ion channels as well as destabilization of what is termed the dystrophin-associated protein complex. So it's that group of proteins that are associated with dystrophin that increases membrane permeability. Both of those result in abnormal calcium regulation. And it's this abnormal calcium regulation that eventually results in cardiomyocyte death and apoptosis. And as the cardiomyocytes die, it induces a marked inflammatory response with fibrosis formation and replacement of the myocardial cells, thinning of the regions of the heart with the fibrotic tissue. As the heart cells replace, the first thing you start to see is problems with the heart relaxing. And then as the muscle cells die away further and you have more and more fibrofatty replacement, you get areas of the heart that are dysfunctional. Then the global function of the heart starts to decrease. And then the heart starts to dilate. And as the heart dilates, then the valves stop to working, and it becomes a vicious cycle. Why I like this diagram is it actually points out that there are multiple things along here besides just replacing dystrophin that you can address with therapies, including the inflammatory response, the abnormal membrane permeability, the calcium regulation. You'll see as we go forward, many of the therapies that we have don't directly affect don't try and replace dystrophin, but in fact attack some of these other areas of dysfunction. So let me talk a little bit about how this shows up clinically. So this is a diagram that, with 3 phases. So this is from 0 to 10, showing what we would call the preclinical stage of the disease. And before age 10, we see almost no overt cardiac dysfunction. We can see very subtle ECG abnormalities. Almost all the patients develop sinus tachycardia, which is essentially an accelerated heart rate, but with a normal rhythm. There's some subtle abnormalities in relaxation, but none of which are really clinically important. Between ages 10 and 18 is where we see the most dramatic changes. Patients lose ambulation at this time. Actually says subendocardial fibrosis. It's actually it's epicardial fibrosis that progresses to the subendocardium. The first change in the contractility we see is actually regional changes in thinning the wall, the lateral and inferior, the bottom of the heart changes first, and then as that progresses, then you can go to global changes in the function, and then finally to dilation. Actually, chamber dilation in this disease is a very late finding, and we don't typically see it until the next phase. So between ages starting somewhere in 18 to 20 and older, nearly all of the patients will have some amount of detectable systolic or pump function dysfunction. They will all have some amount of fibrosis that we can detect by cardiac MRI. About 60% of the patients or so will have symptoms. Eliciting symptoms from this patient population is very difficult because they are non-ambulatory and don't exert much or don't have much energy expenditure. So the classic NYHA heart failure classifications are very difficult to use here. We actually have particular ones for Duchenne, but again, can be very difficult. And then finally, when you get to end-stage heart failure is where we start to see the actual arrhythmias cause a problem. But we're getting better. So this is just looking at survival by era. So on the right is the 60s, and as you work your way to the left, the current era where we have active ventilation and spine surgery, and the survival is much better. This is a survival curve showing the same data, but you can see that the dark line is the previous eras as you work your way up into the current era, where if you look at this, you can see that somewhere, as I said before, about 50% of the patients are alive and well at 27 years of age. And we have lots of patients that are in their 30s and even some in their 40s as well. And people are clearly living considerably longer, better respiratory care and cardiac care. So let me move on to the way we evaluate and treat these patients. This is a very detailed diagram, and the point of it is not to look at all the details. But what I want to get across is the very first thing that we do in terms of evaluation is an ECG and some sort of imaging test. And based on the imaging test, we bifurcate the therapy. So I'd like to talk a little bit about the evaluation first, and then we'll talk about the therapy. So the first thing we do is ECG, and it turns out in looking at nearly 440 ambulatory monitors, we found the percentage of significant arrhythmias is pretty small. So the total percentage was only about 3% if you take all comers. Patients with normal function had very few arrhythmias. When you get severe dysfunction, the arrhythmias get a little more prevalent. But the bottom line being that treating for primary arrhythmias in these patients is pretty rare. It's a little bit of change in paradigm because if you read some of the older literature, it talks about really significant arrhythmia burdens, but that seems to be much better now. So moving on from ECG, we have to do some sort of imaging. Again, I said the symptoms are not easily discernible in these patients, and so the original sort of the way we start with imaging is using echocardiography. The problem with echocardiography in these patients is that the pictures are often quite suboptimal. So this is a typical echocardiogram from a patient who is wheelchair bound with Duchenne Muscular Dystrophy, and you can maybe make out a heart in there, and if you can imagine if it doesn't get any better. So we've actually gone, and a lot of places have gone to doing cardiac MR. We find it replaces echo after about age 6 to 8. We use yearly exams without sedation. The typical exams last about 30 minutes or so. We have an abbreviated non-contrast follow-up exam version that's about 10 minutes. And we've done somewhere in the order of 2,200 exams now since 2004. And let me show you why we like it so much. So this is actually on the left is the cardiac function stack. So this is a stack through the heart, so a short axis through the heart with the left ventricle here and the right ventricle here. You can see this is an advanced case of cardiomyopathy showing the thinning of the wall, the free wall, the lateral free wall. If you could see it playing, you can see that the function is actually quite poor. And it's particularly pronounced up towards the top of the heart. If you look over to the image at the right, this is actually a post-contrast evaluation looking at scar, or what we call fibrofatty replacement. Everywhere that you see white in the myocardium, try to highlight with the yellow arrows, is evidence of this fibrofatty replacement. So normal myocardium should be dark black in this scan. And you can see this is extensive replacement, particularly in the free wall of this patient, again, in a very advanced case. So between these two studies, it gives us some idea of what's going on actually in the myocardium histologically, as well as a very accurate assessment of the function. So taking some of this data and looking at it going forward, what do we see in terms of function as patients age? So on the left here, you can see shortening fraction, which is just a measure of function by we can do by echo or MR, and on the x-axis is age. And so you can see the black circles are patients that are on steroids, and the open triangles are patients that are not on steroids. Everybody's function declines as you age, but you can see that the steroids seem to have a protective effect. And just for reference, on the right is the respiratory function. And so you can see that there's an inexorably progressive decline in the respiratory function, even as the cardiac function for some patients is maintained. Similar data using slightly more sophisticated cardiac MR. So again, we have age on the x-axis and ejection fraction now on the y-axis, and I just marked what was normal and what was abnormal for function. You can see very little dysfunction below age 10. So we really don't start to see dysfunction until you get into early teenage years. The blue diamonds are patients who had no scar on their MRI or no fibrosis noted on their MRI. The red squares are actually patients who had fibrosis. You can see that it's very rare to have dysfunction and not have signs of that fibrosis. And it's a few interesting findings. One, you can see how bad the function gets in some patients, even when they're teenagers, with ejection fractions down in the 20s, which is severely depressed. But interestingly, we have patients that are in their late 20s or even early 30s who have evidence of fibrosis but have maintained their ejection fraction, which is a phenomenon that was thought to not actually, thought to be extremely rare, but now we see it more and more with better care. This is a similar study, but this study looked at if you take the same patient and you image them for 5, 6, or 7 years, what do you find? And everything in green on the left is ejection fraction changes before you get positive fibrosis on your MRI, and then everything to the right is after you have positive fibrosis. And what we found is that on average, the ejection fraction doesn't change until you see fibrosis. But then once you see the first scan with fibrosis, the ejection fraction declines around 1.5 percentage points per year. So progressive decline, but not till after you can see it, which is the reason that we are so interested in doing those studies, to be able to get an idea of when we anticipate patient's function is going to decline. So let me go back to our algorithm just to point out some of the things that we do for therapy. So you can see that the first decision point for therapy is the ejection fraction. So it's the other reason we really like cardiac MR. It's the most accurate way to assess the ejection fraction. And if you're going to make a decision for therapy based on this, we find this to be the most to be important if possible. But you can see that if you go to the left, even for patients who have a normal ejection fraction, which we're going to call 55, everybody at age 10 or older gets put on an ACE inhibitor. And I'll show you data for this in a minute. And then if they have LGE, which is the MR term for having that fibrosis, then we put them on spironolactone. And I'll show you the data for that in a minute as well. If you go to the right now, where you can see that the ejection fraction is less than 55, where there is dysfunction, we actually start an ACE inhibitor as well, and then add a beta blocker just based on the heart failure literature, and then again add the spironolactone if we see fibrosis on the MRI. So this is sort of a schematic of what we have evidence for in terms of cardiomyopathy. All the patients that we see in clinic will have been started on steroids shortly after the time of diagnosis because based on some really good data, this is just one example, it actually prolongs your ambulation. So being on steroids prolongs how long you can walk, and it turns out that, as I showed earlier, it also prolongs your survival, so this and your cardiac function somewhat. So this is survival data from Montreal showing that patients on steroids live longer than patients over. But some of this is due to a cardiac effect. Some of it's obviously due to other effects, primarily pulmonary effects. So then what's the evidence? What's the evidence for ACE inhibitors? So it's pretty good. This is just one example. So this is a study in the pink circles or the red circles are patients that on ACE inhibitors, and the black circles are patients that were after 60 months, so 5 years, that very few of the red circles had abnormal function. The line here is 45%, which would put the mildly to moderately depressed function. So normal function we see is 55. So even if you use 55, very few of those patients decline, as opposed to the patients in the black circles where quite a few of them decline. So based on this data, we actually use ACE inhibitors quite often in these patients, or anybody that can tolerate an ACE inhibitor will be on an ACE inhibitor. More recent data for the mineralocorticoid receptor. So this study was using a spironolactone. It's essentially the same mechanism, but this is an example that showed that the ejection fraction on eplerenone stayed about the same, and patients on placebo in this trial, actually the ejection fraction went down. More detail from that data study is shown here. The study of between 3. You can see that the ejection fraction for the eplerenone, again, the change was 0 as opposed to a small change here. But the other thing that was impressive was the LGE. Actually, it's a small change, but in the eplerenone group, it actually didn't change much. In the placebo, it progressed a little bit. So a little bit more scar, and the function is slightly better, but very small effects on both sides. So let me now move on to the Capricor CAP-1002 technology. As Linda mentioned earlier, it's a biologic agent of allogenic cardiosphere-derived cells. It doesn't act as a stem cell in the sense that it's not actually replacing myocardium, but has thought to have multiple mechanisms of paracrine effect, or essentially effect, including inflammatory, thought to act, at least in parts, to 3 microRNAs. And again, it's been studied quite extensively. The first HOPE study enrolled older patients who had severe or moderately to severely depressed function, and included a one-time intracoronary delivery of the cells. All these patients were on stable corticosteroids, and at this point, there's limited options for these patients because the function, the cardiac function, is pretty well has pretty well declined, and so much of the therapies, ACE inhibitors, and things that we do don't make a big difference here. What we saw was a reduction in scar at 6 and 12 months, measured by cardiac MR or fibrosis. And an improvement in cardiac function measured by systolic wall thickening at 6 and 12 months. And interestingly, even though this was an intracoronary delivery of these cells, we showed improvements, or the improvements were shown in upper limb strength. Here, that's what the PUL here is, upper limb strength, mostly in the first 3 months. And this study was published back in 2019 in Neurology. This is just 4 diagrams from that paper. The upper left shows an example patient. The white signal is scar, showing that the scar improved from baseline to 12 months. You can see that the scar size is documented below in the bar graph. If you go to the bottom right, that's the wall thickening, and again, patients who got the drug are shown in red, and so slightly better wall thickening. And the same is true. You can see that the month 3 PUL scores are considerably higher than the placebo or the patients with usual care. So moving forward, HOPE-2, again, the phase 2 study of DMD patients, but this time delivering the cells intravenously over 3 months, 9 sites now, with a mean age, again, of 14, so about 80% of them are non-ambulant, and all of them are on corticosteroids, looking at the effects of both upper limb strength, but more importantly to me, obviously looking at their effects on the cardiac function. The interim results at 6 months show an improvement in ejection fraction, which we consider to be the gold standard in improving pump function. It's a robust measure, and even though it's an old measure, it actually is probably it's easier to measure than other things when you're talking about pump function in these patients. So I want to spend just a minute or so talking about advanced heart failure therapies. So in most patients now with pediatric cardiomyopathy who have severe dysfunction, we would move aggressively to a left ventricular assist device or to transplant. This is a recent study looking at 43 Duchenne patients with severe dysfunction, and only 4 of them ended up on a ventricular assist device and only 1 with a heart transplant. There's a myriad of issues of why this is true. A lot of it has to do with by the time you develop enough dysfunction that you can actually, that you meet criteria for an LVAD, that in fact you have too much pulmonary disease, that patients are on a trach or they're requiring a ventilator, and that they are no longer candidates for a VAD. And there's ethical issues with heart transplantation that always come up in terms of transplanting patients that we know have this much systemic disease. The bottom line is that both of these therapies are probably underutilized. We'd certainly like to fix this before it got this far. It is an unfortunate character of these patients. So finally, I just want to touch on how we think about therapies in this realm. So this on the right is a diagram that I borrowed from Craig McDonald from a talk that he gave. But the way to think about DMD therapies is not just replacing dystrophin, which is up at the top, is actually all of these other approaches can have some therapeutic benefits, such as steroids, we know decrease inflammation. And again, we think that the CAP-1002 does some decreasing inflammation, probably helps mitochondrial dysfunction, and may actually help in calcium handling as well. So different modes of getting at how we treat this disease. So again, in summary, it's a Duchenne-associated cardiomyopathy is an inexorably progressive disease of variable benefit. Current therapies provide marginal therapeutic benefits. Need a transformative therapy that prevents the replacement of cardiac muscle cells with fibrous and fatty cells, or somehow provides new muscle cells. And with that, I'll close, and I'll be happy to answer any questions.
Thank you so much, Dr. Taylor. We've been working together for years now, and each time I hear you speak, I learn something new, so I hope that our audience did as well. Now, for a quick update on our COVID-19 program, as promised, and then we will take questions on either that or on the cardiomyopathy issues from Dr. Taylor. As of today, several patients who are in the ICU and on life support have been treated with CAP-1002. All the patients we have treated have shown improvements with no safety issues with infusion. We are currently working with our colleagues at Cedars-Sinai Medical Center in preparing a manuscript for submission to a peer-reviewed journal which will provide further clarity on the potential impact of CAP-1002 on patients that were critically ill with COVID-19. However, what I can say today is while that it is very early in the process and that we are only looking at a handful of patients, we are very excited by the results that we have seen so far and have submitted an expanded access protocol, IND, or investigational new drug application, to the FDA to continue the evaluation of CAP-1002 in patients with COVID-19. We are also attacking COVID-19 from another front. We are also continuing our work on a unique exosome-based vaccine with Dr. Stephen Gould, who is a professor of biological chemistry at Johns Hopkins University and who is working directly with Capricor on these efforts. And let me just tell you that this program is moving even faster than I anticipated. If you haven't had a chance to listen to the replay of the webinar that Dr. Gould did for Capricor on March 26th on why exosomes may be a unique and more effective vaccine candidate, please do. It is very enlightening. It is on our website at capricor.com. I look forward to providing updates on that program as details emerge. However, I want to end this call where we began, focusing on DMD. We will have the 12-month data very soon, as I said. We will provide updates as to our plans and the results of the trial very soon. Please stay tuned for those updates. Okay, thank you. Let's just open up the line for questions.